The other angle on kidney medicine that these medications have is their use in making transplant candidates transplantable. I've seen improvements in protein leakage and stabilizing of the kidney function that would have been inconceivable only recently. So there is new hope out there for patients with chronic kidney disease.
Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi and welcome to Diary of a Kidney Warrior podcast. I'm your host, Dee Moore. This is the kidney health podcast that shares real stories and expert conversations to educate, empower, and inspire people living with kidney disease and those who support them. In part 1, we explored how SGLT2 inhibitors and finerenone are transforming kidney disease care. Now, in part 2, we're turning our attention to GLP-1 medications. Could GLP-1 medications help protect your kidneys as well as support your weight loss? Today, we're exploring how they work, their potential role in protecting kidney function, the possible benefits and risks, and what people living with chronic kidney disease should know about monitoring. Before we begin, a quick disclaimer. This episode is for educational purposes only and should not replace personalized medical advice. Decisions about medication depend on your kidney function, blood test results, other health conditions, and your current treatment. Please do not start, stop, or change any medication without first speaking with your kidney doctor, consultant, or GP. Before we get into the kidney science, for anyone who isn't already familiar, can you briefly explain what a GLP-1 receptor agonist is?
Yes, of course. So GLP-1 is a part of the body's way to avoid us overeating. So how this works is, and I like cooking, so I explain that on the basis of maybe a 3-course meal that I cook on a Friday evening to celebrate the end of the working week. So if maybe after the main course, I ask my other half whether she likes a dessert, and she says, no, actually, I'm fine. So this is because GLP-1, a clever hormone in the body, has been released by the small bowel when the main course of the meal has reached the bowel, and it tells the rest of the body that, no, it's okay now, we don't need to eat anymore. And so the GLP-1 receptor agonists, they pretend that we are full. So they cause this signal to be elicited in the body and give the impression that we've eaten enough, even though we've not eaten very much. We've only eaten a little bit and had the this medication to give this effect. And so these are very new and excellent medications to cause weight loss, and they have several beneficial kidney effects. The other angle on kidney medicine that these medications have is their use in making transplant candidates transplantable. This is very relevant for patients who need a kidney transplant, who are overweight or obese and need to lose weight, and particularly for those who are struggling to lose weight in other ways. These could be patients with maybe orthopedic conditions, so they can't exercise very much, or there's just a lot of weight to lose to get them to the point where they can be placed on the National Kidney Transplant waiting list. That's very close to my heart because I do a lot of transplant assessment clinics and waitlisting, and so this is a topic very close to my heart.
I'm very aware that I've used the term GLP-1, but just to make it even clearer, people may be more familiar with the brand names Ozempic, Wegovy, and Mounjaro. So these are the medications, that I'm talking about when I'm saying GLP-1. But what is actually happening to their kidney function during this process?
Yeah, so that's a great question. So sometimes we see a dip in the kidney function when these medications are started, and there are various mechanisms how that can happen. Typical side effects of the GLP-1 receptor agonists are nausea and sicklish feeling, and so the medications also slow down the movement of food in the tummy and in the bowel. And so these medications can cause some mild dehydration. That's one mechanism through which they can upset the kidney function a little bit. But these effects are usually very minor. It's also the case that we've learned so much about how to use these medications safely, and so we're much better in finding the best starting dose for patients and in managing side effects. So this is not something that should worry patients very much. The side effects like nausea and sicklish feeling are also something that often patients only experience when the medication is started. And so it's not it's not often that this is a constant long-term problem. And often it can be managed by reducing the dose or by giving other medications to address these side effects. So overall, many patients find that for many of our patients, these medications are now very well tolerated.
How exactly is GLP-1 protecting the kidneys? Is it purely through the weight loss and the improved blood sugar control, or is there a direct kidney benefit happening independently of those effects?
Yeah, that's a great question. So the honest answer is we don't have all the answers on this. It is a multitude of positive effects. So the GLP-1 receptor agonists reduce weight. Obviously, that's the main intended action. Through reducing the weight, they will improve the blood pressure. In diabetic patients, through reducing the weight, the diabetes control will improve. And so all these combined will have further beneficial effects on the kidney, but there are also direct beneficial effects of this medication on the chronic kidney disease and particularly on the damage in the kidneys and the scarring. So it's the best way of saying it. It's a multitude of positive effects, both direct and indirect.
There's growing discussions in the transplant community about GLP-1 medications. And so really want to ask this question: is GLP-1 medications safe for transplant patients to use?
That's a great question. I love that question because it's a common question being asked of our transplant patients in the transplant outpatient clinics. So we are learning more and more how this medication can be used safely in transplant patients. We were quite reluctant and cautious initially, like with all new medications. What we've learned is that, yes, the medication can affect the levels of anti-rejection medication, but it does so in a very modest way. And so we don't currently recommend the use of these medications in transplant patients within the first year after transplant, but we do recommend it very much in long-term transplant aftercare when the risk of rejection is much lower. We also recommend that when patients have their blood tests for the blood levels of their anti-rejection medication, that they do this on the day before their weekly use of the GLP-1 receptor agonist, for example, when it is given as a weekly injection. This is because the medication can affect the tacrolimus levels and or the cyclosporin levels in the bloodstream, the anti-rejection medication, and we want to get accurate levels of these medication in the blood tests. Other than that, we have learned that they are quite safe in the transplant population. Real problems caused by these medications, for example, acute rejection of the kidney transplant, is unheard of. At least I have not seen this myself or heard of that. And even talking to international experts on this topic, that's not been seen anywhere else in the world. So we believe in long-term aftercare for transplant patients who have significant weight issues and struggle to lose weight in other ways. They are very safe and good medication. The only problem is access. So the problem is to convince colleagues in primary care to prescribe these medications. But I think we should be optimistic. At some stage, many of these medications will go off patent. When medications go off patent, generics appear. And when generics appear, the treatment becomes a lot cheaper. And so watch this space. At some stage in the not so distant future, they will become a lot cheaper. And then I think they'll be used much more, including in the transplant population.
Touching on what you just said, and Dr. Adrian Brown in a GLP-1 interview told our listeners that chronic kidney disease isn't currently one of the qualifying conditions for NHS GLP-1 prescribing. So as a consultant nephrologist, is that something you and your colleagues are actively working to change? And what would it take clinically for CKD to be added to the criteria?
That's a great question. I think we have to be honest, the cost to the wider NHS of the GLP-1 receptor agonist is phenomenal. And so we have to be mindful of that. I think, yes, we can try and campaign for chronic kidney disease to become a qualifier for the use of these medications in the NHS. But as I said in the previous question, I think the only game changer in this regard will be once the cost of these medications comes down significantly, which it will.
So, like a question I asked earlier, in terms of GLP-1 and the benefits for the kidneys, is this again about maintaining kidney function, or could this actually result in an improvement of kidney function?
Usually we're talking maintaining what there is rather than improving the kidney function any further. But that's a great achievement in patients where prior to these new medications, the decline in the kidney function was just relentless. And to stabilize this situation and achieve stability where previously there would only have been inevitable decline is a great achievement in itself.
So, Professor Alex, we've now discussed 3 separate drug classes: the SGLT2 inhibitors, finerenone, and the GLP-1 receptor agonists. There's a growing discussion in nephrology about using all 3 together in what some are calling a triple therapy approach. Is this a real clinical strategy being used today? And do you believe it represents the future of kidney disease management?
Absolutely. So, for example, for an average middle-aged patient with type 2 diabetes, chronic kidney disease, protein leakage, who's also overweight, this is a fantastic treatment. I've seen improvements in protein leakage and stabilizing of the kidney function that would have been inconceivable only recently. So, yes, it is the future, but we're still learning how this works, what level of combination is safe in which kind of patient, and which combinations are best, and what doses can be used. So I think maybe 2 or 3 years from now, this will be the standard for this type of patient.
Can you paint a picture for us? What does the profile of a patient look like who might benefit from all 3? And what would that treatment plan look like in practice?
Yeah, that's a good question. In practice, things always look a bit different than they do in the publications. So it could be someone with type 2 diabetes, chronic kidney disease, maybe stage 3, and heavy protein leakage in the urine. And so a practical question is it safe to start several or all of these together, or should they be started one after the other? My personal preference is to start one of these at a time and then add as we go along. That also makes it easier to deal with side effects, because it's then easier to pinpoint which medication has been responsible for which new side effect. But it is conceivable that at some stage in the future, we may even have combination medication. There could be a pill that contains both an SGLT2 inhibitor and finerenone, for example. And so I think the future is bright in this space, and there will be further improvements in our approach. So the triple combination therapy will be a big part of our routine treatment for this kind of patient, but there will be further refinement.
Are there specific safety concerns when combining all 3, particularly around blood pressure, potassium levels, and how closely kidney function needs to be monitored?
So I listened to a nephrology podcast from 5 years ago where they talked about this and how often the blood tests have to be checked every couple of weeks in the first couple of months. We don't really recommend that anymore. We've learned that the combination is quite safe, and we generally don't recommend any more frequent monitoring than there would have been without the triple combination therapy.
Awareness of all 3 of these drug classes is still very low among kidney patients. What do you think is driving that gap, and what needs to change?
I think that's a great question. I think partly it is because the medications are relatively new. Partly it is that in primary care, there are many other competing pressures and interests and high levels of workload. So that is difficult to expect an average GP to have this on their radar every time they see a patient with diabetes and impaired kidney function. I think over time this will improve. I think the awareness will also improve through improved patient education. There is not much in terms of great patient education on the web that a patient could watch or listen to. and maybe this podcast might actually help raise awareness. I would love it if patients come to me in clinic and ask the question, should I maybe be on one of these new wonderful medications for chronic kidney disease? Can we talk about this? I would love that if patients brought that up in clinic.
Are there any barriers that would explain why suitable patients aren't being prescribed these medications?
Yes, I think one is awareness, both among patients and among other colleagues, maybe in primary care. But there's also the fact that there's a cost implication to these new medications. All these 3 new medications are costly. We have to be honest about the fact that there's a societal cost and a cost to the wider NHS. But then at some stage, these medications will come off patent and that will make them a lot cheaper. And so I think that would be a true inflection point and a game changer again, where we can roll out these medications at scale and where we can ensure that many more patients are prescribed these medications when appropriate.
It's very disappointing that cost would be a barrier, especially as the medications are so effective. But I'm very aware that, pressures on the NHS and, when you compare the NHS to other countries in the world where nothing is free, I know that, we are in a much stronger and better position. But like you said, hopefully as things come off patent and there are cheaper alternatives, this will no longer be a barrier for patients.
Yes, absolutely. And we have to be fair to the NHS. I can prescribe most of these medications without very many barriers. There are some minor barriers, but in comparison to many other countries like the United States, we're very free and privileged in prescribing what patients really need and what they benefit from.
If you could say one thing directly to a kidney patient watching or listening to this podcast who's never heard of any of these drugs, what would it be?
I think it would be that kidney medicine is going through a period of unprecedented change and progress, and there's an incredible amount of hope for our patients. And we can do things in stabilizing kidney function and improving the outlook of our patients that would have been inconceivable only 3 or 5 years ago. It's the best time to be a nephrologist, and it's also great for us as doctors. It makes it so much more enjoyable to see patients and look after them, and we go home after clinic with a big smile, seeing the effects of these modern medications.
What is the single most important question every kidney patient should be asking at their next nephrology appointment?
If you've got chronic kidney disease, particularly due to type 2 diabetes or other causes, and you've got a lot of protein leakage in the urine, ask your doctor at the next appointment, could I be on one of these or several of these modern medications to improve my situation?
So today, Professor Alex, we have talked about SGLT2 inhibitors, finerenone, and GLP-1 receptor agonists. What is your final word of encouragement for the listeners and the people watching this podcast?
There is new hope out there for patients with chronic kidney disease. These new medications are phenomenally effective. I hope I was able to explain this in a way that listeners and viewers could understand. And I would encourage all of you to ask your kidney doctor at the next appointment, could I be on one of these new wonderful medications?
Thank you so much for joining me. Thank you so much for breaking down this information about SGLT2 inhibitors, finerenone, and GLP-1 receptor agonists. I know that this is going to help so many kidney patients out there. So thank you very much.
It was a great pleasure. Thank you.
And that brings us to the end of this 2-part conversation with Professor Alex. I hope you found this 2-part series helpful and that it's given you a better understanding of how SGLT2 inhibitors, finerenone, and GLP-1 medications are transforming kidney disease care. If you've enjoyed this interview, please give this video a thumbs up, subscribe to Diary of a Kidney Warrior podcast, and share it with someone living with kidney disease or anyone who could benefit from this information. I'd also love to hear from you in the comments. Have you heard of these medications before watching this interview? And is there anything that you've learnt today that you'll be discussing with your healthcare team? Thank you for watching. Until next time, take care and choose to live.
Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.